טוב, אז בוקר טוב לכולם, I'll speak in English. So, this is not exactly about the pandemic per se, this is more about the broader impacts that it has on healthcare delivery. The topic is the increased use and access of telemedicine. So, I should have said I'm from here from the Berkeley School of Economics. This is joint work with Liran Einav from Stanford, and Joe Rashba, who is sitting here, is a student here and worked with Clalit Health Services Innovation Arm, and with Ran Balitzer, who was both known for his role in battling the pandemic, but in this case is, I think of Ran more as related to the Clalit innovation side of things. And so when you can give a 40-minute talk, it could be half a seminar or 2 conference talks. So I opted for the latter. We're just revising this for GIA, so I have a lot of robustness tests I will spare you. I'm just going to give you highlights from 2 projects that we did, and this is the first one. So the motivation is very clear. For many years, people talked about telemedicine. It started at the space race in the 60s, but it really didn't take off for various reasons. You had to license, at the state they were practicing. Reimbursement was very limited, and people just didn't sort of trust or were used to using it. As you can see from the US, but actually you have very similar graphs from Israel and other places. Once the pandemic started, telemedicine really shoot to the sky in terms of, this is showing US rates relative to the base rate. So it became something that many people used. But still, even to date, we know relatively little on its impact on healthcare utilization. And obviously, there are many good things about telemedicine. It's convenient. It increases access to people living in remote areas or people that are immobile. It has potentially lower fixed costs, but it's also worries, for example, payers, because it might induce greater use of telemedicine. Maybe if it's so easy for me to talk to my doctor, I'm going to talk to them all the time, and it's going to blow up utilization and healthcare spending. There's also the concern that the quality of my interaction with the doctor could be worse if I'm doing it remotely, and they might just refer me to some specialist, and then there's a lot of potential spending and low value care. Discontinuity could be an issue. Maybe I'm bouncing around people, talking to different providers. So in this project, I'm going to basically talk to you about 2 projects. The first one, we used the expansion of mostly phone and some video telehealth visits during the first lockdown as sort of a shock that we used to explore the impacts of telemedicine adoption. The second is about a digital device that expands the reach of telemedicine by allowing a collection of data at the patient home. So in the first project, we're using the COVID lockdown period, which here you're seeing for Israel, for Clalit Health Services, telemedicine use rates. They moved from about 5 or 6%, mostly physicians following up on exam results with patients, to really very high rate during the first lockdown. But then we see this ratchet effect, which we see all over the world. It returned to much higher levels than before. In here, we're using the fact that Israel had this short period we believed we were sort of New Zealand when we successfully mitigated COVID initially. So we're going to do a basic diff in diff here between before and after the COVID lockdown, using the variation in adoption during the lockdown period. So that's basically the plan. And so basically it's a simple design. I'm going to say more about it, but it's basically a simple design. And we're really using the richness of Clalit data here to just see people using different types of services with their physician and with other physicians. So again, what we're going to do here is we're going to exploit the fact that during the first COVID lockdown, there were different levels of adoption of telemedicine by different physicians. We're going to use it as a proxy for these physicians' patients' access to telemedicine in this short period right after the first lockdown, when Israel pretty much resumed to normalcy before things got worse again. And we're going to do a diff comparing these high adopters and low adopters and their patients' subsequent healthcare use relative in the post-lockdown period relative to the pre-lockdown period. And so a bit of more background, I mean, yeah. So basically our interest here is what are the impacts of patients having access to telemedicine on their healthcare utilization, healthcare costs, what happens in the visit, I mean, everything we can measure using Clarity. Okay, so, yeah. So the question is, what is the outcome of interest? I said that our interest is in healthcare use, healthcare cost, and Kfi raises the point that, quality is hard to measure. So we're going to do a little bit on quality where we can. I'm going to tell you more about it. So bear with me, and let's get back to this conversation when I get to this part, okay? But in a nutshell, this is sort of a valid concern that we have some evidence on, but of course, I mean, remains to be seen. Okay, so we cannot measure, I mean, we're not measuring everything. We're getting some evidence on stuff we can measure. Things like convenience is also not in this, measurement. But let's take stock of what we do, and then we can discuss and see sort of where we stand. Okay, so this is a bit of a summary on what happened to COVID. I think we've all been here, so we know there's this increase that was relatively successfully mitigated initially. So we had this period of relatively few cases. You can see from Google mobility trends that, things got, just like we saw in the previous talk, very different. We think things froze to a halt in April, May, but then we had this relatively fast, bounce back in April and, from the May and June. And and this is basically on the medical side of things. We can see this graph I already showed you about telemedicine use. There was also a slump in overall use of healthcare. This is all, again, representative of the developed world experience that, again, resumed mostly during this, but not entirely during this post-lockdown period. Okay, so these are the basic facts, and what we're going to basically do here is use this variation to kind of tease out this impact of access to telemedicine on outcomes. So in terms of the data, I mean, most people here know Clalit Healthcare Services, maybe even are members and included in this data set. We're sampling all primary care visits of members of all ages, which amounts to 11 million visits of about 4,000 active physicians. We're starting at 2019 to just get the baseline, and we use everything we observe about the patients, not just with their primary care physician, but also across other services. I mean, back to this point, Clalit physicians face a relatively low-powered incentives. They are not paid per service. They're not paid more if they're doing telemedicine or less. So bear this in mind when we should bear this in mind when we think about policy implications to countries like the US or France that use fee-for-service models. Okay, our unit of analysis is an episode starting with an index visit with a primary care physician with nothing before in 14 days except drugs. We're tracking 3 types of outcomes: the decisions during the visit, what happens 7 days after, and what happens within 30 days. So obviously, there is some selection into a setting. For example, mental health complaints, it's all primary care, but complaints about things like depression are much more likely to be voiced in remote visits, and things like trauma are much more likely to be seen in person. So we can't use the visit setting itself and just compare telemedicine and in-person visits. Also, you can see there's like a high socioeconomic patients are much more likely to use remote care. Female patients and doctors, by the way, are more likely to use care. So we know that the visit setting, I mean, there are obvious differences. So the way we're going to deal with it is essentially, as I mentioned before, we're looking at this lockdown period adoption. Here you can see just raw numbers. So basically this scale is what share of each physician's visits during the lockdown period happened remotely. And you can see that about 20% of physicians did very little telemedicine. Of course, it was exempt. I mean, they could still go to the clinic, but a lot of physicians did much more. And about a sixth did really the majority remotely. So we're residualizing this. And I mean, this graph is slightly updated. We figure out there's a mistake, but it looks quite similar. So we see that basically after we regress these raw numbers on everything we observe, which has very rich covariates like the visit main condition and the patient's age and risk score, where they live in terms of small geographic units, the week and stuff like that. We remain with this measure of the tendency of physician to adopt telemedicine beyond the observables, okay? And that's what we're using here for as a sort of a quasi-experiment, right? So some physicians, even within the same clinic, seeing patients of similar age and gender and so forth, do more telemedicine during the lockdown and some do less. And actually it's quite predictive of what happens after the lockdown. So we use this differential adoption as sort of the variation that we're gonna use to identify patients' access after the lockdown. So how do we do that?
The assumption is that any characteristics of the patients that are captured by the observables, so there's no unobserved patient characteristic that they sort according to that to the physicians, because I mean, you said there is a big difference over own income, for example. So that
sure.
captures basically everything, other than there is no sorting.
Well, if there is some sorting into the physician, we still have physician fixed effect. So
yeah.
If a physician has some very different, so we don't need there are no differential, exactly. There's no differential. So this is the identification assumption here. There's no differential sorting on unobservables, exactly.
Dan, you're not interested in physicians' characteristics?
So we do, and for the interest of time, I'm not going to talk about it. There are some interesting patterns. For example, female adoption, even after the pandemic, we thought initially it's about, availability of daycare. I mean, it's much higher. More experienced physicians use it, younger physicians use it. So we do a lot about heterogeneity in the paper, but I'm going to be brief here. So in terms of so this is the design. I mean, to Itai's point, this is a diff in diff, so we assume parallel trends. We're doing a bit about it. I'm not sure I'll get to talk about it. There are some concerns here about pent-up demand, but the idea basically, again, is we're trying to compare patients of physicians that adopted a lot of telemedicine and patients or their primary care physicians happen to adopt less telemedicine, and we're comparing this before and after the first lockdown. We got the lockdown data. We just used the lockdown to measure adoption, but not outcomes, because it was really an extreme period, so we're not doing that. And another important thing is that we're basing everything on the affiliation in 2019. So when I say a patient's physician adopted telemedicine, they could go see anyone, and that's part of the nice thing about the elite data. You can really see what they're doing. It's all endogenous, and we're capturing it. We're just using this as sort of for the measurement of their exposure to telemedicine. Okay, so you can see that there are indeed differences. For example, high adopters, which as I mentioned tend to be female, more experienced, younger doctors, have different tendency to refer, for example, in the baseline period of 2019, but this is extremely correlated. So the correlation is like 0.98 or something like that. So we see very, very parallel pre-trends. Of course, there's a question of post-trends which are not observed, and I'm going to talk more about it. But, and this is basically sort of reassuring, so it explains why we're using physician fixed effects, and it's also reassuring. So now I'm going to basically tell you briefly about the results, going from sort of top level or bottom line numbers about utilization to more granular things like quality, per first comment. So overall, there was very little. So how did these things look? These are the coefficients from the diff in diff. This is just the baseline mean. So for example, if you look at primary care episodes in this 2-month period, similar to the post-lockdown, about 18% of credit patients have a visit, and that increases by 0.6 percentage points, namely a 3.5% increase over the baseline. So people with high access to telemedicine overall have higher primary care use, slightly higher, not much overall healthcare utilization, and their total cost, if anything, slightly decreases. So what explains this discrepancy? The fact that the episodes become slightly less intensive, as we're going to see. Okay, this is now again showing, this is sort of a summary plot showing this coefficient from the diff in diff, measuring the impact of access to telemedicine. And this is the baseline mean, and this is the percentage change. So 57% of Clalit patients in 2019 that went to see a doctor got a prescription. The number is slightly lower for those with high access to telemedicine. Again, this is measured across all their visits. It's not a in-person versus remote comparison. It's just overall, these patients had slightly, if anything, slightly less intensive use of resources and care during the visit. Okay, so slightly more visits, slightly less intensive. We see more follow-ups though. So about 30% of the patients had a follow-up a week after the primary care visits in 2019, and that number increases by, again, 8% relative to this baseline. So this could reflect a few things. It could reflect the fact that it's much easier to talk to your doctor now over the phone to follow up. So maybe we just split the care for the same episode. Instead of telling you, only come back if you have fever, you can check with me in a week. The reassuring thing, I mean, people might worry about continuity, but it's really mostly with the same physician and much more likely to happen remotely. However, this could also, to field questions, reflect sort of uncertainty about the diagnosis, errors, reversals, and things like that. So,
regarding the previous graph, this is where things were. So this is in the beginning of that COVID period, right?
No, this is in the post-COVID period of May and June, relative to 2019 until February of 2020.
So this is not the outcome of the telemedicine visit?
We're thinking of these numbers as the effect, think of it as the effect of having a doctor that adopted a lot of telemedicine, which I showed you briefly is associated with you doing much more telemedicine yourself, relative to someone who had a doctor that does little telemedicine, which means they are mostly going in person, after relative to before. Okay, it's a diff and diff, so it's a 2 by 2. Okay, so relative to these baseline trends, we see that telemedicine adoption is associated with all these changes. Yes?
So a small question, just maybe you're going to get to that. Is it the selection of people who are, now asking for appointment, or is it something about the treatment? Because is it just for them, for those who have better access, it's easier to get an appointment, hence less sick people are actually...
There is a slight increase, but it's relatively small, right? So
you're saying in an accounting says first it could be 0 and still it could be different people, not just...
yeah, but on average, I think of it, first of all, I don't think of it as large changes.
I think it is those who are less sick are now the one that you see, because it's easier for them to actually...
So I think on the margin, it's likely, we don't decompose this. It's an interesting idea. On the margin, I would suppose the slightly less sick people come, but we don't have, I think, a way to directly measure this or decompose this.
Dan?
Yes.
If you stay on this bottom line, isn't lower care intensity contradicts the more all follow-ups go up? Missing something.
No, so this ties it all together. So these are the 30-day cost and use measures. So again, we're looking at this index visit, and this is for the sample of people who had the visit in the post period, comparing those with high and low rates of telemedicine use. You can see that overall cost of all healthcare services, it's the baseline, it's 565 shekels, and it goes down by 5%. Okay, so there's basically no change in their healthcare use. That's how I would read this. Slightly more primary care, and perhaps slightly less, although it's really not significant, of everything else. So I mean, in some sense, you can think of it as a null result, but a good null, right? Not much changes when people shift we're talking about 20, 30% of their healthcare use to the phone. What 20, 30%? Of course, the endogenously, determined by patients and physicians, 20, 30%. It's not like we randomly assign telemedicine visits to trauma patients. Of course, we wouldn't, right? We shouldn't. So this is basically trying to kind of see what happens when you push the system to do more telemedicine in relatively regular times. Of course, it's still post-lockdown, so it's not exactly regular, but I mean, if you think of it as the experiment, that's what it tells you. Slightly more care, slightly less intensive interactions, and not much happens to everything else. Of course, going back to Kvir's questions, there's a question of what about quality? Maybe this, we're not doing the same medicine, so we can't say for all these conditions, but we did choose 3 conditions that are chosen because they're reasonably common and seen in both in-person and remote settings. They're very unlikely to be confused with COVID. So we didn't take strep throat, for example, and seemed likely to be annoying enough or severe enough so that we could observe false negatives, by which I mean that if the patient comes with urinary tract infection and gets misdiagnosed, not treated with antibiotics, it's likely that within 30 days we'll show her popping up in an ER or another doctor's office, and we'll see a diagnosis reversal. So we're trying to measure these, and this is a proxy for quality of the diagnosis. Another issue is that we can't just look at UTI diagnosis because the diagnosis here is the object of interest, it's endogenous. So what we're doing is basically using the set of what is called differential diagnosis. So we're looking at all the genitourinary conditions that have the same complaint, some of which urinary tract infections are treated with antibiotics, some are basically very different and should be treated differently. So we're doing two things. We're measuring out of all these conditions what fraction was diagnosed with as the target condition and how did it change over 30 days as two ways to measure quality of the initial diagnosis. And this is, we're doing it for UTI, heart attacks, and fractures, which satisfy these conditions. So these are the results for UTI. Obviously, things are much less powered. We're talking about 15,000 visits, not millions now. And we're seeing that 40% of the baseline group of these conditions in 2019 were diagnosed as a UTI. And there's no change, no significant change, at least in these rates, again, with telemedicine exposure. So this suggests that physicians are not doing poorly, at least on UTIs. We again see there's a slight increase in the baseline diagnosis rate within 30 days, even in 2019, and there's no significant change in this change of the diagnosis between the index visit and within 30 days with any provider. So this is hopeful in terms of nothing blows up, at least where we can look. Maybe it's not significant, slightly more testing. Test positivity though is slightly higher, so they seem to be testing to confirm, but I don't want to make too much of it, and here we're really underpowered. So again, and the power is even worse for AMI and fracture, so we can't say much, when you drill to these specific conditions, and I think this is an open question, what exactly it does to quality, but at least we could look, things didn't blow up, so it's hopeful.
By the way, do you check if they had COVID? I know it's unrelated to COVID, but control for COVID?
So we're talking about a period where there were post-lockdown, there were single-digit number of COVIDs per day in Israel. We're talking about very low COVID time, which is why we're using it and not like later periods. We also use, I'm at the robustness, I'm not going to talk about it for, but we're worried a little bit about pent-up demand, the idea that, just a sec, patients sort of with low access to telemedicine during the lockdown period actually did a lot of stuff right after, so this would bias, or violate our design. But we're actually seeing that this increase is actually concentrated in less deferrable conditions, which is the opposite of what you would be concerned about. Happy to talk more about it. It's kind of really a brief talk, so I'm not going to dwell on it. The results are also robust to using, instead of this immediately after the first lockdown, the period a year later after 80% of the population was vaccinated, and we're seeing very similar trends in terms of utilization and use. So that's kind of suggestive that it's not really some sort of lockdown spillover effects that we're measuring here. And then we did a lot of robustness tests that you could see in the paper, and now we're even doing more. So this is quite robust. So, yeah.
Can you track repeat use? Like if I was satisfied using telemedicine, and we can't use it again?
Yeah, we see these patterns.
And that's
Yes.
on an individual level.
Yes, we do see this. So this is what you're suggesting is consistent with the evidence. Again, also by, from surveys and information we have, like
Review preference, right? And use it again.
yes, yes. I think this is why it sticks partly because people sort of it's kind of an experience good in some sense, right? Talking to a doctor over the phone or video. So to wrap up, so in this analysis, that has obviously some limitations in terms of the design, but we get some preliminary evidence on what is the impact of increased access to telemedicine, and we see this increase in use and follow-ups but not much evidence for a huge increase in cost or for a decrease in quality, at least for the diagnosis we could study. Yeah.
I'm not sure if you're able to answer this question, but I know, at least from anecdotal evidence, that even hospital division managers, ראשי מחלקות, claim that exactly in the first lockdown, people avoided getting serious treatment for serious conditions in hospital because they are afraid to come in for telemedicine,
Yes.
to hospital. Wouldn't you expect not to see a small increase in telemedicine, but a lot of increase and then a lot of follow-up?
Okay, so that's a tricky point, but let me get to it because it's important. I think everything we do here is a difference in difference. So there were obvious time trends in the tendency of using care and for specifically for different conditions, right? But again, we're comparing here two groups, the ones with high access to telemedicine, the one with low access to telemedicine. So as far as the design is concerned, what we care about is this differential tendency to use care. So this is a little bit related to the point about deferrability that I talked about. So we try to define this notion of, whether people just come up with all the stuff they deferred from the lockdown period, and they could potentially do it differentially between the group, which would be a concern, and we showed that they didn't. So we measured deferrability exactly by how big was the dip in conditions used during the lockdown. So if it dropped a lot, we say, well, that's the deferrable condition. If it dropped just by little, we said it's a non-deferrable condition. Even during the lockdown, you still seek care for this. And then we saw that we didn't find these hypothetical concern of differential trends in the use of, in pent-up demand, essentially, in deferrable conditions. And all this increase in utilization that I showed you is really concentrated in non-deferrable conditions, suggesting that access to telemedicine really makes people more likely to come when they have some minor acute condition that is non-deferrable, so that it increases on the margin that you would expect.
But does it contradict then this anecdotal reporting of the...
No, it just doesn't apply differentially to the groups. I mean, the trends were just absorbed by the, time-fixed effects here.